Good morning, everybody, and I hope you've got your reading glasses on. Here we go. Rheumatic fever is an unpredictable response to Group A streptococcal sore throats, the most severe consequence of which is rheumatic heart disease. First episodes of rheumatic fever are prevented by timely administration of antibiotics, and further episodes with long-term injectable penicillin prophylaxis. The incidence of rheumatic fever has declined in the developed world, but in New Zealand remains a marker of social inequity, which is likely to be due to a combination of crowded housing, socioeconomic deprivation, barriers to access to healthcare, and therefore a higher burden of untreated streptococcal sore throats, mostly affecting our Māori and Pacific populations. Associated with the National Rheumatic Fever Primary Prevention Program established in 2011, the Ministry of Health commissioned a study to understand the lived experiences of Māori and Pacific peoples living with recurrent rheumatic fever and unexpected rheumatic heart disease. Kaupapa Māori and Pacific, Talanga and Kakala approaches were employed. Semi-structured whanau or individual interviews were conducted with 80 Māori and Pacific patients and their whanau, and focus groups and semi-structured interviews with 33 secondary prophylaxis and other healthcare providers from 7 high-incidence DHBs across the North Island. Many of these whanau are living complex lives with inadequate or unstable housing and often highly mobile. They are experiencing financial hardship and often lack transport. When food, shelter, and just surviving are the primary focus, health becomes a low priority. 12 patients experienced delayed or misdiagnosis because of a lack of healthcare provider awareness, at times despite whanau themselves trying to convince the doctor that their child had rheumatic fever. Hospital was sometimes a culturally unsafe environment. Some patients reported frank racism, being treated differently from other patients, being treated as dirty because they had rheumatic fever, and being called coconut. Parents felt unsafe leaving their children because of this. Whanau experienced fear and guilt. Hospitalisation of children caused significant disruption to their lives and serious economic consequences. Welcome support was received from hospital social services. Pain and embarrassment reduced adherence to injectable prophylaxis. Adherence to prophylaxis was facilitated by whanau support, rapport with healthcare providers, continuity of care, and community delivery. Some healthcare providers clearly go above and beyond the call of duty to support patients and their whanau. Patients, their whanau, and healthcare providers all highlighted the difficulties for adolescents and young adults of being diagnosed with rheumatic fever or rheumatic heart disease, and the need to be adherent to injectable prophylaxis. Adolescents experienced embarrassment, social exclusion, and for some, lost their identity because they were unable to play sport. Not exercising led to weight gain. For some, contracting rheumatic fever spelt the end of their schooling. Adherence to prophylaxis and engagement in healthcare was challenging for all. Patients in Whaanau had good understanding of the importance of sore throat management, but for many Whaanau, the publicity campaigns engendered guilt and stigmatised them because their children had developed rheumatic fever. Patients and Whaanau found communications with healthcare professionals jargon-laden and unintelligible, and called for more visual resources. Understanding of the rationale for prophylaxis was low or forgotten. 2 recurrences in this group were directly attributable to a period of loss of supply of benzathine penicillin nationally. Adherence to prophylaxis was supported by seamless transitions. In some DHBs, prophylaxis was delivered through 3 different systems, depending on the age of the patient. Many patients were mobile, and some DHB systems remain paper-based. Tracking patients' movements within and between DHBs is highly problematic. Patients, whānau, and healthcare providers all called for a national patient management system to facilitate the delivery of prophylaxis. There are a small number of key recommendations. Firstly, that our health service delivery models need to be flexible to take into account the complexity of people's lives. The supply and quality of affordable housing in urban and rural areas needs to be improved. A seamless, coordinated national patient management system is required across all DHBs. Return strategies for exercise, education, and employment should be implemented. Rheumatic fever and rheumatic heart disease requiring long-term prophylaxis should be recognised as chronic conditions in adolescence. Even if you have no cardiac damage, you are still required to be adherent to injectable prophylaxis every 28 days for a minimum of 10 years. This is not a normal adolescent experience. Age-appropriate resources and services are required for adolescents, and healthcare professionals need training to provide care and support to adolescents. Consumer insights need to be obtained to inform the delivery of culturally safe services and need to be engaged in the preparation of health promotion messages. And we need to strengthen our performance in our own backyard. Thank you.